So I'm going to talk about the UK guidelines for the management of inherited bleeding disorders in pregnancy and delivery. And these guidelines were published in the British Journal of Obstetrics and Gynecology last year. And the guideline writing group comprised haematologists, obstetricians, scientists, paediatric haematologists, and there was input from midwives and obstetric anaesthetists. And we were working under the auspices of the UK Hemophilia Centre Directors Organisation and the Royal College of Obstetricians and Gynecologists. So the guideline covers the broad categories of the congenital bleeding disorders: haemophilia, von Willebrand's disease, rare factor deficiencies, and platelet function disorders. Now, you will know that although these are in 4 broad categories, there's a huge variety of types of severity and the different types within these categories, and hence this guideline is actually 71 pages long. So anyone studying for the MRCOG or the MRC path absolutely hates me because they feel they have to learn everything for the exam. But I say when you are a practicing obstetrician or haematologist, you will be very grateful because it does give a lot of specific detail about these specific conditions. So the aims of our guideline were to advise on methods of determining carrier status, to stratify the bleeding risks to the mother and the bleeding risks to the baby, to understand the factors involved in considering the mode of delivery, and to consider best management in the antepartum, intrapartum, and postpartum periods and the care of the neonate. So, although haemophilia is a condition that predominantly affects men, there is increasing recognition of its impact on women. So, males with haemophilia, they do not pass on haemophilia to their sons because their sons inherit their normal Y chromosomes, but all their daughters will be carriers, so we call this obligate carriership. The carrier women then have a chance of passing on the mutated X chromosome, causing an affected haemophilia boy. So that boy will have a 50% chance of inheriting haemophilia, and the girls will have a 50% chance of being a carrier for haemophilia. So it's becoming recognized now that although levels of factor 8 and 9 in women are typically half that of the normal level, that is actually the bottom end of our normal range. However, women do bleed too, where there are hemostatic challenges. So childhood epistaxis, menorrhagia, and bleeding after childbirth. So furthermore, it's very clear now that the range of factor levels is very wide. So this cross-sectional observational study by Rosendal's group of 247 genetically confirmed carriers showed that the range was between 0.05 IU per mil right up to 2.29 IU per mil. So that range is really huge, and about 40%. About 25% had levels less than 40 international units per mil, and that is consistent with mild haemophilia. So this wide range is really due to a process called lionization, which happens early in embryonic life, and there is random inactivation of the X chromosome. And because it's random, it may be skewed or unbalanced, and 35% of women have a greater than 70 to 30 skew in their pattern of lionization. 7% have more than a 10-90 skew in favor of one parent's X. And perhaps it's not as random as we thought. There is some evidence of genetically determined patterns of lionization. with good cells predominating over mutated cells. And an example is marsupials, who perhaps have the right idea in that they inactivate all the paternally derived X chromosomes. So we know from Rosenthal's group research that even levels of around 50% or 50 international units per mil, bleeding patterns can be increased by about threefold. The risk increases as factor levels fall, but it's not closely correlated, and there are other factors that interplay. This study of known carriers showed that after childbirth, 10 of 22 patients had prolonged bleeding, and the median factor VIII level in these patients was 59%. So therefore, when we're considering how to manage women in pregnancy, we need to think of three things: the inheritance risk to the baby, the bleeding risk to the baby, and the bleeding risk to the mother. And that will be determined by the type and severity of the inherited bleeding disorders. So in determining the inheritance risk to the baby, we need to construct a pedigree. Now, it might be that we know the carrier status of the mother, but in many cases we don't. And this is an example. This lady, generation 3, number 2, she presents to the obstetric haematology clinic, and she says, I have a brother and a maternal uncle with haemophilia. What are my chances of having an affected boy? So we need to draw up this pedigree, and we can see, therefore, that this lady, her mother, is an obligate carrier because she has an affected brother and an affected son. So she is an obligate carrier. So therefore, this lady has a 50% chance of inheriting the mutated X chromosome from the obligate carrier. And if she has a 50% chance, then the chance of an affected boy is 12.5%. This is quite a common scenario. This lady has an unaffected boy, and then out of the blue, with no family history, she has a baby boy with haemophilia. And she needs to know, well, what are my chances of having another affected son? So to consider this, it's very unlikely that the mutation occurred in oogenesis, in her embryonic development. It's more likely to occur in spermatogenesis because there's a higher turnover. So it's likely that the mutation arose in this gentleman here. And that is the case in 90% of times. Therefore, she has a 90% chance of being an obligate carrier. And therefore, there's a 45% chance of an affected boy. So tests for carrier status will include the factor level, factor 8 or 9, and we've seen that some carriers have low levels, so that's confirmatory of carrier status, but it might not be low. And the other thing is we can do a specific mutation analysis, but that does rely on us knowing the specific mutation in the proband, the affected male. So genetic counselling prior to pregnancy includes discussion of the severity of haemophilia, so we can determine the risk to the baby if he is affected, the inheritance pattern within the family to identify obligate or possible carriers, and the risk of transmission to the fetus. We also need to explain to them the limitations of carrier detection techniques, which I haven't gone into, and options for prenatal diagnosis. So this table is in the guideline. What are the options for prenatal diagnosis? Well, we do recommend that all carriers for haemophilia do have free fetal DNA assessed after 9 weeks gestation for the gender. And then if it's a male baby, that would inform whether they would like to go on to analyze for the specific mutation, haemophilia mutation, either a chorionic villus sample from 11 to 13 weeks, which would be the preferred, or a bit later on, amniocentesis. We also recommend that if these are not taken up for prenatal diagnosis, an amniocentesis is done at 34 weeks plus in order to determine whether it was a male, whether it is affected or not, and that would help inform delivery. PGD is also offered and funded and may be helpful for carriers of severe haemophilia to be able to select non-affected embryos if they should wish so. So we then need to consider how to manage the woman in pregnancy, and this involves how to cover the antenatal period as well as delivery. And there are antenatal procedures, and I've just said the chorionic villus sampling or amniocentesis may be taken up. There may be bleeding or threatened miscarriage or a real miscarriage. And although factor VIII levels rise in pregnancy, this may not have occurred to a sufficient level by these antenatal stages, and factor IX does not increase. So to cover these procedures or miscarriage, women may need factor IX concentrate or DDAVP to increase factor VIII levels. So what about DDAVP in pregnancy? There was a lot of concern about it in the historically, but there's definitely growing experience of its safe use in pregnancy, and I, for one, don't have any problems using DDAVP in pregnancy. We know also that the peptide does not pass into breast milk. So DDAVP will increase factor VIII and von Willebrand factor levels by releasing them from the stores in the endothelium. Razan Kadir conducted a systematic review of DDAVP in pregnancy 5 years ago, looking at patients who had received it, so mostly von Willebrand disease patients, some haemophilia A carriers, some platelet function disorders, acquired haemophilia, and Ehlers-Danlos. Mostly it was given by intravenous infusion, as it was largely in those days, but some intranasal. 51 cases received it antenatally and 172 in the peripartum period. And the majority had absolutely no complications and no bleeding. In the same study, there was one premature delivery and one water intoxication seizure. So these were in the same study, these two. And certainly outside of pregnancy, I've seen a water intoxication seizure in a patient who received DDAVP for von Willebrand's disease. They were on a medical ward for UTI, had drunk loads of water, and there was no water restriction. And so they had a hyponatremic seizure. So the guidelines do state that fluid restrict to less than 1 litre over the next 24 hours after receiving DDAVP, because it is an antidiuretic, so it will conserve water. Oxytocics do that as well, so it's very important to be cautious in the use of DDAVP when giving oxytocics. It's not to say that they can't be used together, but we need to be very careful about fluid restriction afterwards and avoid it in preeclampsia where there are blood pressure problems and fluid balance problems. So the management of delivery in pregnant carriers must be a multidisciplinary discussion, including discussing with the patient. There needs to be a written delivery plan drawn up in advance, and that needs to be disseminated not just to the patient and the registrars, but to delivery suite, to the obstetric anaesthetist. Everyone needs to know about the delivery. It's no good just having a plan and actually not telling people about it. We need to have an up-to-date level on the mother, and the obstetric anaesthetist will particularly want that. So check the factor level of the mother in the 3rd trimester if it had not been normal prior to that. If it had gone up to nice normal levels before then, it doesn't need to be repeated. And obviously the obstetrician will need to know the fetal sex of the baby. We don't really know what factor level we need for a safe delivery. There really is very little evidence on this. There is data in the normal population to show how high the factor VIII and von Willebrand factor levels rise in the peripartum period, and they do go up to 200 to 300. So we're traditionally aiming in our haemophilia population for levels over 50%, so that might not be sufficient. And I think it's important that people are still aware of the bleeding problems that may occur, even if we're accepting 50% as a reasonable level for safe delivery. So if one has to give factor concentrate, factor IX, or if they didn't, then to maintain the trough level of 50%, we really need to be getting that peak level up to 100%. What about regional anaesthesia? The obstetric anaesthetist and we would say that the required level is at least 50%. There are very good alternatives to neuraxial anaesthesia now, and these include remifentanil and patient-controlled analgesia. So it's important that women do have the opportunity to discuss those different modes of analgesia with an obstetric anaesthetist. There's a lot of controversy about the mode of delivery, whether we should be offering caesarean section to all women who are at risk of having an affected male. And the recommendations from the guideline are, yes, we are. That's why we're keen that everyone is offered an amniocentesis at 34 weeks. Because if the baby boy is unaffected, then we know that they can have a normal delivery. And then it's just the bleeding risks of the mother that you're concerned about, and that can be well managed. But if they have an affected boy, whether it's mild, moderate, or severe, then we would offer a caesarean section, but it would be discussed. We're not mandating it. And it's very important that the patient's preferences and the bleeding risks to the mother, the reproductive choices, all those things need to be taken into account when we're considering mode of delivery. Because if a woman plans to have several more children, we need to be careful about doing caesarean section on the first one. So what we're concerned about is the bleeding risk to the baby. And we can see that the risks of intracranial hemorrhage in haemophilia are 44 times the risk in the normal population. So the absolute levels are still low, but nevertheless, that's a huge fold increase. And this was shown in Roseanne's systematic review in 2016. And it's affected by the mode of delivery. So the odds ratio compared with an uncomplicated vaginal delivery is over 4 times if it's an assisted vaginal delivery, but less than half if it's a caesarean section. So this is an elective caesarean section. And this is the increased risk is shown also in the normal population by the study by Towner, who showed that the highest risk was with von Toos delivery, forceps, emergency section, and the lowest was an elective caesarean section. So therefore, if a vaginal delivery is opted for, and we know that we don't know that the baby is at risk of haemophilia, then we would say avoid these aids to delivery. Now, these are, in fact, important aids to delivery, and that's why we really want to ascertain whether this baby is at risk or not. So from that third trimester amniocentesis, if it's not at risk, then we can allow these important, helpful aids to getting the baby out. Now, in the guidelines, we've drawn up a table which I hope is helpful of all the inherited bleeding disorders, and it stratifies neonates into high risk, medium risk, mild risk, and unlikely risk, and gives them a suggested management of delivery according to their risk stratification. So you can find this table in the guidelines. How do we manage the neonates? Well, we need to check the cord factor level, withhold intramuscular vitamin K until the result is known, and it's unlikely you'll get the result fast enough, so vitamin K to be given orally. And if delivery has been traumatic or prolonged, then recombinant factor 8 will need to be given to the baby if the levels are low, and consider ultrasound or CT scan of the baby's head after a difficult delivery. Postpartum management of the mother is very important. Levels start to fall after about the third day. Tranexamic acid is usually sufficient, but what's important is to follow up, recheck the hemoglobin, and to make sure that they are reporting heavy bleeding, because remember, many of these women will be very used to menorrhagia and heavy menstrual bleeding. It's important that we check more objectively whether they are having that increased bleeding and check their hemoglobin. So in summary, recommendations for haemophilia carriers, it's very important to have multidisciplinary planning. We need factor levels in the mother so that we have informed management for her bleeding risk. We need to plan for all eventualities. So it's not just the intrapartum period, but it's everything that might happen to her antenatally and postpartum as well. We need to identify the fetal sex from 9 weeks. And if early prenatal diagnosis is not taken up for male babies, then we need to offer late amniocentesis to see if the baby is affected to inform delivery. Unaffected babies can then be managed as normal, and if the mother's not at increased bleeding risk, that can actually be delivered in a local unit. It's very important that we discuss delivery with the woman so she is, and her husband, so that she is able to take informed decisions about how she would like to deliver her baby. So moving on to von Willebrand's disease, this is quite different because it more clearly affects women. It's common, and the bleeding pattern is quite different because the von Willebrand factor is involved in the platelet pathway, so platelet adhesion, which then triggers the platelet activation and aggregation pathway. So the bleeding pattern is more mucocutaneous, with epistaxis, uterine bleeding, bruising, as opposed to haemophilia, which is more joints and muscle bleeds. As you know, von Willebrand's disease is subclassified into type 1, the various forms of type 2 and type 3 disease. And so type 1 is quantitative deficiency, type 2 is qualitative, so the molecule is abnormal, and that can pose problems for pregnancy and delivery. And then type 3, where von Willebrand factor is absent. So your next talk is about the rise or the changes in factor during pregnancy, so I won't talk much about that, but you do need to know the von Willebrand factor rises like factor 8 does as pregnancy advances. So for us with managing patients with a mild type 1 disease, most of them get to normal levels by delivery and they're of no complication. Pre-pregnancy management is really important. We need to assess the bleeding phenotype, and we need to recap over any historical diagnosis. So von Willebrand factor can change with age. We need to have an up-to-date factor level. Check their baseline investigations and establish what response they've ever had to DDAVP. We need to consent for the use of plasma products, because this may be the first time that a woman has ever had plasma products when she enters pregnancy. We also need to make sure she's had her hepatitis A and B vaccinations, discuss a management plan with her and her own bleeding risks and any risks to the baby. So we need to check the factor levels. We've done the baseline. We need to check them again in the 3rd trimester. And like with our haemophilia carriers, we're aiming for a level of more than 50 international units for delivery and regional anaesthesia. DDAVP may be used, but again, beware of potential for fluid overload, and you need to fluid restrict for the next 24 hours. Caution with aspirin and non-steroidal anti-inflammatory drugs. Obviously, prenatal antenatal aspirin is used very commonly in women these days for the prevention of preeclampsia, and that's often okay for women with von Willebrand's disease to have that, but you need to know that their levels of von Willebrand activity are above 50% for them to have the antenatal aspirin.
So you have 3-4 minutes.
Okay, thank you. So the risks to the baby are not as severe with the haemophilia unless both parents have von Willebrand's disease and have a risk of a child with severe type 3 von Willebrand's disease. Type 2B, I'm not going to talk about, but that is another more major risk to the baby, as the platelet count can be very low at delivery. But you're going to have a talk on that later on in this session. So again, stratification of neonatal bleeding risk is important, and the different types of von Willebrand's disease are within this table, giving suggested plans of management and delivery for the baby. Same with the maternal bleeding risk. According to the different type of von Willebrand disease, the mother's bleeding risk is stratified with suggested management for care. So postpartum bleeding in patients with von Willebrand's disease can be quite significant, and it's important again to follow them up, to give tranexamic acid and repeat hemoglobin if necessary. What about the rare bleeding disorders? Again, women are affected just as much as men. There's usually parental consanguinity. Generally, I mean, there are many rare bleeding disorders, but generally 20 international units are sufficient for hemostasis. And expectant management is often reasonable, but it's important to ascertain their bleeding phenotype. That's true for factor 11 deficiency as well. We need to ascertain it with a good history what the bleeding phenotype is of that woman. And if we don't know, then it's reasonable to offer expectant management, being able to jump in with some treatment when, if there is unexpected excess bleeding. Just a particular mention to afibrinogenemia, because fibrinogen is necessary for placental development, for adhesion, and without it, the fetus will be lost. So anyone with afibrinogenemia will need prophylaxis right from this onset of their pregnancy if they were not on it before. And the same for factor 13. Factor 13 is necessary for implantation, and prophylaxis needs to be started right at the onset of pregnancy. So, in conclusion, it's very important that management is multidisciplinary, bringing in the obstetrician, the anaesthetist, the haematologist, as well as the mother and father. The prenatal diagnosis must be offered for carriers of haemophilia. In fact, it's only requested by the minority of women, but therefore the 34-week amniocentesis is very useful to help inform best delivery and safest delivery of the baby. Levels of factor 8 and von Willebrand factor rise in pregnancy, and hemostatic support is rarely needed to cover delivery for women with mild von Willebrand's disease and for factor VIII deficiency. DDAVP can be used in pregnancy for those conditions, but obviously it doesn't work for factor IX deficiency. Normal delivery should be a routine option, but with recourse to early section if necessary to avoid instrumental delivery. But carriers who are expecting an affected baby boy should be offered caesarean section, and many do prefer that option. There is a risk of intracranial hemorrhage in the baby, and there is a significant risk of postpartum hemorrhage in women, particularly those with von Willebrand's disease.